conference held in Patna, and we'll kickstart the session today evening. That is Teachers Speak on Orbit and Oculoplasty, Session 1. Our chairperson is Dr. Kasturi ma'am, and our first speaker for today is Urmil Chawla ma'am, and she'll be speaking on ocular surface disorders and enigma decoded.
Not a single entity, but it is consisting of multiple factors which we would be taking one by one. Being blessed with a normal ocular surface is really a blessing, and we realize this only when we sit in a dry eye clinic and we see the miseries of patients. And normally we also see that sometimes we do a very good cataract surgery, 6/6 vision, we are very happy, patient is happy, but after a few days the patient comes, niradak ho rahi hai, takleef hai, maza nahi aaya, he's not happy. And we look for a number of reasons, and most of the time general ophthalmologists basically they get rid of them by giving lubricating eye drops. But what we should be careful is that not all ocular surface diseases or all such disorders are to be ruled out just by giving artificial eye drops. We should think of a normal ocular surface. You can see over here, this is a normal ocular surface with a shining light reflex showing that the epithelium as well as the tear film is normal. The conjunctiva, the limbal stem cells, the lid, the tear film, everything is to be normal. Normal layman considers, or a normal general ophthalmologist considers only the tear film as to be responsible for the ocular surface there, but there are multiple things we need to be take care of. Like in this picture, you can see we should have in mind all these disorders that can lead to ocular surface anomalies. Is this pointer working? The adenoviral conjunctivitis, which happens before, after, and during it, we have the ocular surface problems. The allergic conjunctivitis, asthenopic symptoms, canaliculitis, thyroid eye disease, contact lens disease. Second line beginning, you can see the lag of thalmos or the filamentary keratopathy, concretions, the aqueous dry eye disease, the blue film. Then you have this multiple use of drops with preservatives. Then you have this floppy eyelid syndrome. Some of the pictures you can see over here, this lid viper syndrome. Then you have this, ye chal nahi raha aapka? Chal raha hai? So we have this picture of Muhammad Ali where you can such patients with Parkinsonism, they usually are very poor in blinking their eyes. They can sit before you for a few minutes and not blink their eyes. And there where the problem of ocular surface develops, various systemic diseases, acne rosacea, all these multiple things, they can lead to ocular surface problems. Now this DUS2 report that has standardized many things, but it has at the same time complicated also. Whenever we come across a patient having dry eye, we put them to a triage of questions. And if we find the answers positive, we can go for these OSDI questionnaires. And after the answers of these, we can go to the markers, the non-invasive, then the osmolarity, then ocular surface staining. Once these are also positive, we can conclude that he is suffering from dry eye. But then we have a spectrum on dry eye, the evaporative ones and the aqueous deficient ones. Again, we need to do a few investigations, the tear meniscus height and the meibomian gland diseases, which are nowadays more often labeled for this problem. So all these things, they are done, but all are instrument based. So and all obviously costly. So these this non-invasive BUT test, then the tear meniscus height test, then this infrared meibography for the lipid layer. All these tests, they are definitely machine dependent. The reports are there with us within minutes, but then they are all costly and are not possible for every patient. So let us listen to the patient and be firm about a clinical examination. We should ask about the duration, severity, progression, the initiating, aggravating, and the ameliorating factors, the diurnal variation, vision, treatment history, and systemic history. OSD as such is not a condition that will be cured 100%. It is a chronic disease and it has to be taken wherein there are relapses and remissions, so we have to teach the patient like that. We should use these tests rationally, the BUT, Schirmer, and the lipid. All have their own, if all are normal. If only the Schirmer is decreased, we see that it is an aqueous dry eye disease, which is preclinical. If along with Schirmer, the BUT is involved, it becomes the clinical. Similarly, if the lipid problem is there, it is the evaporative dry eye disease, preclinical, and with BUT, it becomes the clinical. So we should be carefully using this and reaching to our inferences. And then we have to have a practical approach. The age of the patient, we know it's more or less a middle-aged disease, but youngsters are nowadays also equally getting involved. Symptoms and signs generally often don't correlate. Then ocular staining should be done, and coexisting ocular conditions should be kept in mind and ruled out one by one. Systemic evaluation, again, many of the these autoimmune and rheumatic diseases are known to have these problems. The treatment mesh has to be considered, and keep reviewing the treatment and evolve long-term maintenance strategies. As I told you, the condition is going to remission and relapses, so we have to have the patient on long follow-up. We can follow this protocol of the routine investigation, the ESR and CRP to rule any chronic inflammatory, the RF and ANA, very common causes of dry eye, blood sugar, because many of these patients need steroids, so we should be knowing their diabetic status, the chest x-ray, urine, all for tuberculosis, and if you find dry mouth or other symptoms, the Jogren markers should also be ruled out. There are newer drugs available, few not in India, but chloroquine is there. Then there's another concept of true tears. When the afferent system is not responding or it is fatigued, the ocular surface is not involving, there are prongs available to, which are used in the nasal area to stimulate the secretors, and they stimulate the lacrimal gland, and true tears are kind of developed. These are moist chamber glasses, which are very commonly used for these patients. Then punctal plugs, the silicone plugs, wherever we're possible, we can just insert them into the punctum. They go deep and they help us to maintain the, avoid this overflow. Then again, another form of punctal occlusion is when a rectangular strip can be removed over the punctal area, and another strip from the fornix is taken and it is sutured over there. 4 corners are sutured with Vicryl, and over the time period, the punctum may get occluded. Then there's another concept of tear volume is to surface area ratio. Whenever we have certain conditions like this is a hereditary autoimmune disease which is not going to improve much the patient's cornea, the lateral tarsorrhaphy has been done to decrease the little bit of surface area so that the ratio can be maintained between the volume and surface. Now MGD is another reason for the evaporative type of dry eye disease. We ought to be aware of the normal anatomy by clinical awareness daily. If you examine your patients, it is not always that you have to do a meibography to be knowing about the status of the meibomian gland. You can just evert the lid and have a look and you get a rough idea, because a meibomian gland, these streaks that are present are visible and they are responsible for the slow evaporation of tears and clear optical surface. This is a case of congenital absence of the meibomian gland, only one is present, and similarly the meibography will show this, anti-BUT will show this test, the breakup time would decrease. Then this is the anatomy, the meibography that can be done. Then this is a spring-based device that is pressed over the lower lid in the middle area, and the secretions that come out from the meibomian gland, they help us to find out how the severity of the meibomian gland dysfunction. And then again, this infrared laser can be done to see the thickness. Normally when we press, a drop of fluid should come out, but if it is a spurt of fluid, it comes as out from the duct area, it is a seborrhea. Sometimes it is the toothpaste-like appearance that come out due to marked inflammation, the meibomitis, and sometimes it is so, even after excessive pressing, nothing comes out because they are atrophied and no secretion is there. That is the meibomian Sicca disease. There are other things, these cloudy appearance, all these changes during MGD, you see this frothy appearance in the lid margin. These are the collarettes and the Demodex disease which will come, MGD plus disease, the Clasion. Corneal changes can be seen, and this is the Demodex blepharitis, we see on the lash lines. If it is a seborrhea, we get, on staining, we get a short BUT dry eye disease. If it is a Sika disease, we see this kind of picture because of the evaporative dry eye problem which is there. Further advanced inflammation due to meibomitis can lead to this kind of picture of flictanular keratoconjunctivitis, and later on the cornea may get involved and perforation can also occur. So one has to be careful. So while treating this MGD, we have to keep in mind the cause, whether it is the quantity of the secretions, whether the quality or the inflammation. If it is the quantity which is the problem, then warm compresses, lid margin scrubs and massage can be done. And nowadays LipiFlow is in there, half an hour massage is done and it is repeated in regular intervals. It is giving good results. If the quality is involved in these drugs, azithromycin, doxycycline and omega-3 fatty acids have been found to be helpful. Then there's another, this intense regulated pulse light therapy which is given, which again helps in improving the quality of the meibomian secretions. If inflammation is the cause, then again steroid, tear substitute and cyclosporin. So if we do not use this drug, the condition will deteriorate and corneal scarring, as you see in the last stage, can be there. So we should avoid these. Plus disease, Clazion has to be treated, Demodex with these treatment is there, and keratinization is also there, which can be treated initially if topical retinoic acid or even mucous membrane grafting may be needed. Papillae are another cause for these ocular surface diseases, giant papillae. They can also lead to shield ulcer, and so they have to be taken, they can be removed, as well as supratarsal injection can be given. Localized keratinization can be removed, but it again recurs. If it is just removed, we should use topical retinoic acid, and slowly after treatment it resolves. Lid margin, if it is keratinized, then the way out is the mucous membrane graft from the buccal mucosa. Using the fibrin glue and the sutures, we can put these mucous membrane graft for both the upper lid and the lower lid. It can be used. Then the another thing for OSD is the pterygium. This autograft is the best way to treat it. In primary pterygium, you may avoid reaching to the limbal stem cells, just free autograft can be taken. But if it is a recurrent pterygium, it is better to use from the limbal based graft. Again, dermolipoma with limbal dermoid, another OSD problem, again can be treated. It is easily removed with a crescent knife, and AMT is very well used and gives good results. Then OSSN, another cause of ocular surface disease, interferon alpha 2b, known to give good results in very localized ones. However, if it is a diffuse one, the no-touch technique can be used, and AMT also, if needed, can be used. Lastly, we come to the limbus with the limbus stem cells. This is a case of chemical burn. We can see acute damage of the limbal stem cells. This is the normal eye. So wherever, this is another case where there's total deficiency. So limbal stem cell replacement has been done. We remove this pannus, and then from the normal eye, you can use the limbal stem cells from areas and implant it over there, and gradually it shows improvement. However, with Dr. Virendra Sangwan's and other from LV Prasad, this simple limbal epithelial transfer technique has also come up, where these limbal epithelial grafts are taken, and first the amniotic membrane is put over the pannus areas and deficient areas. Then these limbal grafts are put and over with fibrin glue and with the contact lens, and slowly these patients are known to recover. Allografts can also be used. So to sum up, whenever there's a dry eye dysfunctional tear syndrome, these are the first line, second line, starting from the tear drops and going to later on to the eyelid surgeries, wherever the causes can be found out. And finally, the take-home message would be, since it is a disease of patients' expectations also, and education is a must, they should be knowing that it is a chronic disease that is not going to cure within days or completely cured at times. So long-term therapy for a chronic, has to be given for this disease. It minimizes worsening, and we should minimize the worsening and maximize the comfort and vision. Start with least expensive therapy, not already tried, and give patients hope and options for advanced care if needed. Thank you so much.
Thank you so much, ma'am. Any comments from the...
So in periphery, we don't have any investigation. Suppose a patient comes with severe dry eye in a young lady. She used to work in a plant area, so there's a lot of dust exposure. So what is our management?
Initially, you have to educate her, especially if you are saying she's already in a dusty and such an environment. If it is life is to be made comfortable, she has to be taught and told that she has to think of alternative ways to begin with. And then obviously you'll start with your artificial teardrops, frequent and lubricating, these moist chamber glasses, and then obviously you'll find out other causes if you can detect for the meibomian gland disease. If that is the reason, then you have to go accordingly, the massage and warm compresses. So investigation as much as you can do, otherwise you have to refer the patient.
Should we go for cyclosporine to start?
Just to begin with, if after you've given a course of artificial teardrop not responding, I don't think there's a harm if you give a trial of cyclosporin.
Her reading is, thermos is 0, both high. And there is no MGD.
There is low?
No MGD.
Oh, there's no MGD.
No.
Okay.
And absolutely, and she suddenly come with this symptom. And previously she is all right.
No reason, you can't find out any other reason?
Nothing. She just came with the pain. And when I detected Sarma test is 0, she is also surprised. So what to do?
I think so. No improvement. Okay. No, then you've started it right, but I think you can add, in this case, yes, you can try that. You can try punctal block. No, if you've already given for 2 months, you are saying you've given the treatment. So you can go ahead with that. Yeah, you can go ahead, try that. Cyclosporin can also be tried. But there should be some cause. There's nothing you could detect. So you can suggest something? This is for another patient you are saying? Okay. Yes, that is it. Okay. Thank you.
Thank you, ma'am. Dr. Debraj Shom is not here, so we'll move on to our next talk by Santosh Nawaz sir. Sir needs no introduction, and I think all of us are looking forward to his talk today. Minimal interventional procedures for orbital tumors.
Good evening. I'll be speaking about some of the minimally interventional orbital procedures. I won't call them surgeries because not all of them are surgeries. I'll be touching upon non-surgical approach to orbital tumors, minimum access surgery, and also target therapy. You might be wondering what non-surgical approach to orbital tumor could be. Like, this patient has no proptosis at all, but he has a problem. He's an airline pilot who was failed in his recent medical exam because he has visual field defects. On further evaluation, he was found to have a orbital cavernous hemangioma, which was impinging on his superior orbital fissure and the optic nerve as well, causing this visual field defect. Now, cavernous hemangioma is surgeon's delight. You would all want to operate on a case of cavernous hemangioma. But what are the consequences of meddling in the superior orbital fissure area and the orbital apex in a person who is an airline pilot? Obviously, you may cause diplopia, which is not existing at this point in time, or further reduction in his visual field. In this patient, we choose not to do surgery and choose stereotactic radiation instead. And you can see that the tumor has regressed by about 70 to 80%, and his visual field defect also has returned to normal. So sometimes not doing surgery could be a wise option. This was reported in the literature where gamma knife radiation was used in an exactly similar situation, which much worse visual field loss, and you can see the tumor has reduced in size and visual field has dramatically recovered. This is from the literature. So current concept is that whatever tumor that you may have, if it's a benign tumor or a malignant tumor, if there is posterior orbital extension like this, if it's in the shape of a pear, then you have to be very careful during surgery. But if it is posterior orbital clearance and it's more of a spheroid tumor, then you can very well excise it. Coming to injections. This young lady wants cosmesis in her right eye. She has axial proptosis, recurrent subconjunctival hemorrhage, all resulting from a lymphangioma. The problem is with her is that it is all over her optic nerve, lateral rectus, lacrimal gland, SRLPS complex, and the medial rectus. Even if you were to do a what is called a safe debulking supratemporal approach, she'll still have some complications, or she may not be completely rid of a problem. So in such situations, we use injections. In this patient, we use picibanil, which is a much friendlier drug as compared to bleomycin, since it was a predominantly intraconal lesion around the optic nerve. And you can see that over a period of time, her intraconal component has regressed, her extraconal component has regressed, and she has gotten the cosmesis that she wanted. This was only with injections. If you have a patient with macrocystic lymphangioma, you try to aspirate the blood content within the lesion and inject equal or half the quantity of bleomycin or picibanil with good results. This was a patient where somebody else had attempted a biopsy from this vascular lesion and had abandoned because of intraoperative bleeding. And at that point, the patient was referred, and all that we needed to give was one injection of bleomycin. Similar case here with a chocolate cyst, aspirated and bleomycin injected. Anterior lymphangioma, treated again with bleomycin. So bleomycin or picibanil work very well for venolymphatic malformations. Shefali already presented this, a patient with a similar case with eosinophilic granuloma, where the dura is already involved. In such patients, curettage is not an option because dura will get further damaged and the patient may need neurosurgical intervention. In such situations, we do a safe biopsy from the center of the lesion, which is absolutely safe, wait for histopathology on the table while the patient is under anesthesia, and then inject triamcinolone. This patient needed 2 injections. You can see after the first injection, there was partial bone remodeling. After 6 months, second injection, there is complete bone remodeling without need for a major surgical intervention. These are similar children where eosinophilic granuloma was treated by the same approach. This is a patient with a large orbital dermoid, but the problem with it is that it's temporal to the lid crease. So this patient does not want a scar at all. She wants to rid of her orbital dermoid without a scar. So what can be scarless? If not doing surgery, you can use alternative modalities such as intralesional injections. Here we use what is called sodium tetradecyl sulfate, which is a volume expanded injection. We aspirate the contents of the dermoid, and before aspirating, we should be sure that it is fluid content, not a pultaceous content or a lot of hair within it. Then it is impossible to aspirate. You can see that the content in this dermoid was absolute fluid. It was a straw colored fluid that was aspirated. The needle is held in position, and then an equal amount of sodium tetradecyl sulfate, which is volume expanded, is injected. That's how we do the volume expansion. We create a foam out of sodium tetradecyl sulfate and we inject right within the lesion, and over a period of time, lesion partially or completely resolves. In minimal access surgery, we have transconjunctival approaches. Almost 2/3 of the orbit is amenable to transconjunctival approach. Just about the superior orbit obviously cannot be approached transconjunctivally because SRLPS complex is right in our way, but the entire medial, inferior and lateral orbit is amenable to transconjunctival approach. This was a patient with orbital teratoma, a young child with orbital teratoma, all around the optic nerve, medial as well as lateral. That was a fully grown molar tooth, within it confirming clinically the diagnosis. This patient was a swinging eyelid incision, which is all along the lower fornix with a lateral canthotomy and an inferior cantholysis. That's the cystic lateral component, that is the optic nerve that is seen, and medial to this was the solid component, that was the groove through which optic nerve was passing. And this patient has no stigma of surgery. Of course, he still has esotropia that needs to be corrected. Disc edema went away after 1 week following surgery. This is a patient with intraconal cavernous hemangioma, young lady who wanted early recovery and no visible scar of surgery. Again, a transconjunctival approach was used in this patient. It's a very simple surgery. Start with a lateral canthotomy and inferior cantholysis. Go expose the inferior orbital margin, make a periosteal incision, dissect the periosteum till you see one of the endpoints, that is the apex of the inferior orbital fissure or the infraorbital nerve, beyond which you stop dissecting the periosteum. Curvilinear incision in the periorbita orbita in the on the quadrant where the tumor is located. Dissect the tumor using blunted instruments. About 2/3 of the tumor is dissected, before which we apply a cryoprobe, which is a 3 millimeter cryoprobe. Get a good purchase over the tumor and very gently wriggle the tumor out. And as the tumor comes out, you have to look for the posterior vascular pedicle that needs to be cauterized. And all that we need to do is close the lateral canthal incision and a few sutures through the inferior conjunctiva. These patients invariably do well following this surgery, and this is the same patient after a couple of weeks following surgery without stigma of orbitotomy, and similar patients treated with transconjunctival approach. So I would end there because my time is already up. Target therapy is something that we can cover sometime in the future. Thank you so much.
Dr. Rolika Bansal will be presenting on orbital dermoids, a systematic approach. She is currently doing a fellowship in Center for Sight, Hyderabad, under Dr. Santosh Navasa. So while it is being set up, sir has a question for Santosh Navasa.
Excuse me, sir. Sir, injection bleomycin you are injecting under USG guided, yeah, just. USG guided is not really required. You have a good estimate of the depth of the fissure. But if it is very posterior, then you may want to. Some colleagues are telling that I have given the bleomycin injection intraorbitally and patient lost the vision. That is very unusual. I haven't seen a case of that. Because one of my colleague told me, and so that I was scared. If I will go for the bleomycin injection and something mishappening is there, then what I will do? This is the big issue, sir. If you're not sure where the lesion is, then you can always do a CT guided. CT guided injection is not possible in the lower setup, sir. Radiologists are not cooperating. Thank you, sir.
Over to you, Dr. Rolika.
Okay. Good evening, everyone, and thank you, AIOS, for the opportunity. I'll be talking on orbital dermoids, a systematic approach, and I thank my mentor for giving me the opportunity to see such amazing cases. We have no financial interests. So, orbital dermoids are basically developmental benign chorostomas. Most commonly, it is the most common orbital tumor of childhood. Which occurs due to ectodermal sequestration along the lines of embryonic fusion of mesodermal processes, which is basically abnormal tissue in the normal location. And it constitutes to 3 to 9% of all the orbital masses based on the previous studies, with variable presentations. And as we have observed in our study also, the dermoid constituted as 4.5% of all the orbital tumors. The mean age was around 15 years, and it ranged from 9 days to 63 years as well. And we of course saw a drop in the occurrence of dermoids because as I mentioned, it starts from childhood and birth as well, and we had an equal gender predilection. The clinical presentation was variable, asymptomatic mostly it presented since birth. It was painless, palpable mass often, with forward protrusion of the eyes. Redness and swelling was also one of the clinical presentations. amongst the case presentations, like the signs and symptoms that we observed, we saw most oftenly the patient presented with palpable mass. And those are the lesions which are more anterior. It constituted to 89% of our cases, and they also present with fixity often in 45%. That means that there is an underlying bony involvement as well. Patients will also present with restricted motility or proptosis. Proptosis occurs when there is a posterior mass. Over here we had 11% of our cases were posterior lesions. And the patient can also present with dystopia, ptosis, oscillopsia on mastication, or even diplopia can be present in the cases with dermoid. Swelling, pain, and redness occurs when patient presents with a history of trauma or injury over the lesion, which leads to rupture and causes swelling, pain, and redness. So basically, orbital dermoids can be external angular, internal angular, intraosseous, or even dumbbell or hourglass. So we have to remember these possibilities of the locations. Anterior orbital lesions, radiological investigation is quite mandatory in these cases because you need to localize where exactly the lesion is present and what are the adjacent structures involved. Like over here you can see this is an anterior orbital lesion, this is a posterior orbital lesion. This is a sutural lesion, and it's a dumbbell dermoid. As you can see very well, it is going into the bone, and there are like two components, one in the temporal fossa as well. And over here you can see these are the variable presentations that we saw, and we should do a 3D bony reconstruction. As you can see in the pictures below, fossa formation can be seen and bony excavation can be seen. So this gives us a preoperative estimation of how deep is the lesion and what are the what is the exactly involvement of the bone as well, because you might have to do marsupialization if you cannot excise the lesion completely, and if it's a dumbbell dermoid, then we might have to do a bone cut, which we will be discussing. MRI is quite recommended. If at all the patient cannot afford, then CT might suffice, but MRI is recommended in these patients because this will give you an idea about the adjacent structures involved, as I mentioned. So in patients who have ptosis, you can actually counsel them preoperatively that what can be the postoperative possible complications. And so orbital dermoid cyst management basically could be conservative because these are benign lesions, or surgical, which was sclerotherapy, excision biopsy, or marsupialization. Conservative approach, as we can see over here in this case, we managed the case conservatively. Dermoid cysts are basically slowly expanding. This is due to the constant desquamation of the epidermal lining and the secretions of the dermal glandular elements. And you can see that this patient after 4 years presented to us with an increase in the size, and eventually we had to go ahead for excision biopsy. And so excision biopsy is the option that we most often resort to. Here is a patient who presented to us after observation for a few months, and we go layer by layer dissection. Mostly the presentation is external angular, as I have not mentioned though, but external angular is the most common presentation. We have to go layer by layer dissection. It's quite important. And remember, these lesions are extremely thin-walled. So going layer by layer is quite difficult as well for the surgeon. And these lesions might look simple, but they're very difficult to dissect around. Because of the chronicity, there are multiple layers around it. As you can see, the lesion is extremely thin-walled, and the surgeon had to go all around, and you can see the transillumination. Nicely the vessels can be seen. And posteriorly, the pedicle was excised and tumor was excised completely, and the patient is doing well. Histopathology is mandatory. We have to make sure that we have histopathologically proven diagnosis of orbital dermoids as well. These are the lesions that we have seen which have done extremely well with excision biopsy only. And the complications that can occur are periosteal tether, bony erosions, fistula formation, and intraoperative rupture. We have seen the cases with periosteal tether and intraoperative rupture and bony erosions, but we have not seen any of the cases with fistula formation. Sclerotherapy, as sir has already mentioned, has given excellent outcomes. These are few of the pictures. I'm not repeating the discussion because sir has very beautifully explained it. And these are the patients who have done extremely well. We might have to do 1 or 2 sittings of the sodium tetradecyl sulfate injections, but the patients do very well, and it's a very aesthetic approach. So this is just a comparative study that we put together for the previous large studies that have been quoted. So the age range quite well matched. Superotemporal quadrant is what we have also seen to be the commonest site of presentation. Dumbbell dermoids should not be missed. 21% are dumbbell dermoids which require meticulous excision, and intervention was excision biopsy. However, our presentations ranged from excision biopsy, sclerotherapy, marsupialization, and we had 3 cases of rupture as well, which are lesser than the other cases because we landed up making sure that we excise it with radiological investigations as well. So imaging was done in all of our cases, and all were histopathologically proven, and at the 12.6 years of follow-up we have had no local recurrence. So these cases do very well. So to conclude, developmental benign chorostomas are the most common orbital tumor of childhood. Age range, as we have seen, could be 9 days, even birth, to 63 years. Locations were most commonly external angular, internal angular or intraosseous, and even dumbbell dermoid are seen commonly and can be managed well with bone cut technique, where we excise the area that is involved. We remove the segment of the bone in toto. And variable presentations are seen, so you should be prepared for all. Palpable, anterior, cystic to firm mass, well defined with or without fixity. Excision biopsy, sclerotherapy, and marsupialization are the possible interventions, and residual tumors, if at all any, can be treated with excision biopsy and sclerotherapy with no local tumor recurrence. So in short, a good clinical radiological assessment is mandatory to localize the tumor and assess its relations and extent to decide the line of management with histopathological confirmation to ensure local tumor control with aesthetic outcome. Thank you so much.
Thank you so much. Any questions from the audience?
Thank you.
We move on to our next talk, which is by Dr. Hariram Oja sir. He'll be talking on full thickness skin grafting in cicatricial ectropion.
वीडियो पेन ड्राइव में है सर? पेन ड्राइव ठीक।
Good evening, everyone. Sorry for delay. I am going to talk about the full thickness skin grafting in cicatricial ectropion. Basic introduction, we should know about the cicatricial ectropion. Cicatricial ectropion is a version of the eyelid, upper or lower, due to the vertical shortening of the anterior lamella. Basic causes, trauma, burn, cicatrizing skin tumors, medication like dorzolamide, brimonidine, allergies, and skin condition just like as the ichthyosis. Earlier, one of the resident mentioned about that. What is the pathophysiology of the cicatricial ectropion? This is the scar formed as a consequence of wound healing in which the normal skin is replaced by the fibrous tissue. And basic clinical feature, epiphora, redness, tearing, foreign body sensation, and most important, the cosmetic blemish. Clinical evaluation, first of all, preoperatively, we have to do the extent of a scar, appearance, its color, thickness, maturity, and most important in the lid position examination, because we are doing grading on the basis of the lid position. We are dividing the cicatricial ectropion in the 4 parts: grade 1, grade 2, grade 3, and grade 4. In the grade 1, part of posterior lid margin not opposed to the glove. In the grade 2, whole length is not opposed. Grade 3, palpebral conjunctiva is visible, and grade 4, fornix is visible. Non-surgical management of the periocular scar, we are doing a scar massage, pressure therapy, silicone gel, intralesional steroid, triamcinolone we are using. In the surgical management, in the mild to moderate cases, ZSW-plasty we are doing. But in the moderate to severe cases, always we are doing full thickness skin grafting. Basic concept about the skin graft, we are the mainly 2 types of the skin graft: split thickness and full thickness. Split thickness, we are using the you are retrieving the epidermis and part of the dermis, but in the full thickness we are retrieving the epidermis and whole of the dermis. For the split thickness graft we need dermatome, but full thickness grafting we need nothing more than the scissor and forceps. Mostly FDS is needed for the periocular reconstruction. What is the graft site? Most commonly we are trying to do the contralateral ipsilateral upper eyelid. If patient is elderly, a dermatocallosis is there. Then after that, post-auricular skin, that is the most common site. We are taking the, most common site we are preferred as a ophthalmologist to take the graft. Then preauricular skin is also there, but visible scar mark is there, so that patient is not very comfortable with the preauricular skin grafting. Supraclavicular inner upper RSM we are not using. Generally plastic surgeon are doing this. This is the a short video in which patient we are doing the full thickness skin grafting in the cicatricial ectropion. Here we are releasing the cicatricial scar. Volume is there. Yeah. Okay. We are marking the template of the defect. By anything we can mark it. Just we have used the sheet of the drape sheet, and we transfer the template in the retroauricular area and just harvesting the full thickness graft from the retroauricular area. Volume is not there. Yeah. And then we are removing the subcutaneous tissue from the graft and making the multiple punctures over the graft to avoid the collection of the blood. Then we are first of all taking the 4 anchoring sutures by the 5-0-ethylone in the 4 cardinal areas. And after that we are doing the base suturing to avoid the decrease the potential space, so that hematoma collection will be very less and graft chances of acceptance will be increased. And rest of the area we are continuously sutured by the 6-0 Vicryl. Then we put the bolster. We can use the anything for the bolster, just like here we are using the just this thing gauze piece and put the over ointment over the graft to avoid the just adherence with the graft of the bolster. And we are removing the bolster after 1 week. This is the post-op after 1 month, and now graft is accepted. Then we have to know about the steps of the graft take. First of all, the phase of imbibition, first 2 days. That time graft color is the pale and white. And next is the phase of inosculation, 2 to 3 days. That time graft color is the patchy pink. And last one phase is the phase of revascularization. This is the very important phase. This takes 3 to 7 days. That time new vessel in growth into the graft from the recipient wound bed, and now graft color is converted into the pink. Bolster removed after the phase of the revascularization. Generally we are removing, someone removing 5 days, someone removing after 7 days. And first after that, most important thing is the early complication. What is the complication of the FTSG? Less common but most important complication is the graft failure. What is the causes of the graft failure? Large and thick graft, hematoma collection, infection, and displacement of graft within 1 week. Then we have to come to the long-term complication. Long-term complication, most important, what is the graft contracture? Primary or secondary? If graft contracted, then again it will come at the same place. Then patient are shouting to you, what you have done, and how result is the same. Then we are very much difficult position what we will do. So we are not answerable. After that, I want to know, sir, what we can do after the graft contracture. By Santosh, sir.
You can give 5FU is one option, 5-fluorouracil.
Yes, sir.
Or early, if there is contraction, like within 6 weeks to 3 months, then you can give triamcinolone under the graft and around the graft.
Under the graft.
And around the graft.
No, sir. I am talking about after 1 month or 2 months, patients are coming with the again contracture. 5-fluorouracil. Thank you, sir. And next long-term complication, the color mismatch. I have not answered what we are doing for the color mismatch.
You can't do it.
Similar things, sir. We are not doing anything. And both are less common but difficult to manage, because this is some type of complication we are not able to manage. And we are now trying to find out what others are doing for this thing. And another one is the most common, hypertrophic scar. This is also most common. Everything, this girl has, I have done everything, but after 1 month again coming with the I don't like this one scar. Then what I have done, in the case of the management of hypertrophic scar, I have taken the steps. Initial scar massage by the antibiotic steroid ointment, mostly resolved in the few weeks. If not resolved, then we are infiltrating intralesional steroid. Multiple sitting may be needed, and scar massage by contra-tubex ointment 2 to 3 times per day. It little bit decreased but not completely resolved. So I think everyone following this management for the hypertrophic scar is something different. I want to know by audience if anyone doing something different, everyone doing similar thing. I think everyone doing similar thing. Thank you. Thank you, sir.
Thank you, Dr. Hariramji. One question is, can we give us a placentrex extract injection? No. Have you any experience of placentrex injection intralesional?
No, sir. No, sir. Nothing. I have even not given the 5-fluoro. Urmil Chawla ma'am using 5-fluorouracil nicely and talked multiple times, but even I have not used the 5-fluorouracil till now. I will try. Thank you, sir.
Thank you, Dr. Hariramji. Next speaker is Dr. Neha Sri. Topic of discussion is tackling the complex eyelid deformities.
Good evening all. I'll present tackling complex eyelid deformities. So, eyelid is a complex structure, and tackling the complex deformities becomes major challenge, and we often need to take road less traveled. I'll not discuss the basic principles. I'll just going to discuss few scenario here. नहीं वो सी वाला है आपके पास, वो नहीं आएगा उसमें.
खाली टाइम तुम दिखाते हो, काम नहीं करते हो.
नहीं तो है यहाँ पे. या कोई लगाओ ना, ये वाला लगाओ ना. अभी तो सो रहा था ना उसमें. Sorry for the interruption. Yeah. पकड़ के रखना फिर इसको. हाँ ठीक है. ठीक है. ठीक है. Pinter है मेरे पास. लेकिन ये तो आएगा ना, लैपटॉप से करेंगे. नहीं लैपटॉप से चेक करना. हाँ कीनोट नहीं है, मैं पावर पॉइंट है. आप ये करो, ये करो. पावर पॉइंट तो नहीं है इसमें डालना. या we have connector, ma'am. Yeah. Connector is there. Yeah, I can. एक मैम को देख लो. इसको यहाँ पे रखो. ठीक है. No, I have in pen drive. I'll try with pen drive. नहीं हो रहा, पेन ड्राइव से कर लेते. Yeah, the wire is loose, I think. हाँ ठीक है, लीजिए पेन ड्राइव। ठीक है, कोई नहीं, पेन ड्राइव निकाल लीजिए। ठीक है, I'll try with the presentation ये कहाँ पे है सर? ये नहीं, presentation भी नहीं है इसमें। Presentation भी वो तो slides में है ना। अच्छा चलो ठीक है। So yeah, sorry for the interruption, and I'll start with the tackling complex eyelid deformities. So eyelid is a complex structure, and eyelid is a complex structure, and tackling the complex eyelid deformities becomes a major challenge, and we often need to take road less traveled. I'll not discuss the basic principles here. I'll just go through few case scenario. And first I'll discuss iatrogenic eyelid defects after tumor removal, eyelid deformities after chemical injuries leading to ectropion and lagophthalmos, post-traumatic eyelid deformities, and combined deformity of eyelid and ocular surface in chronic cicatricial diseases. So my first case is about a 50-year-old male who presented with the right eye lower lid mass. It was a cauliflower separate papillomatous lesion arising from the lower lateral fornical conjunctiva involving the lateral canthus. And there was no palpable lymph node. On clinical diagnosis of right eye sebaceous gland carcinoma was made. So a repair of the defect created iatrogenically often becomes challenging when it involves medial canthus and lateral canthus. This was almost 50% of the defect which we can see here, and it also included the lateral canthus. So first of all, posterior lamella was formed by taking the pedestal graft from the lateral orbital bone, and then the anterior lamella was formed by taking the advancement flap we can see here. So this is the post-op pre-op photo, and this is the post-op photo showing well-formed upper lid and the lower lid. Second case is about a 60-year-old male presented with a complaint of mass in the left eye upper lid for 7 months, which were gradually progressive and increasing in size. Left eye upper lid has a multinodular, we can see here, it has a multinodular black pigmented lesions with the area of minor ulceration, loss of hairs, loss of margin and contour. The clinical diagnosis of pigmented basal cell carcinoma was made, and after the excision there was 80% defect size was noted, and it also involved the lateral canthus, but we had 4 to 5 mm of remaining area near the medial canthus. So for this situation where we have a very large defect, we might need more than one flap or graft for the reconstruction. Here for the medial defect, we can see here cutler beard were used. This is the posterior lamella of the cutler beard. This is the anterior lamella. And for the lateral defect, again, like the previous case, posterior graft was taken for the posterior lamella and the advancement flap for the anterior lamella. This is the 6-month post-op photograph of the patient showing well-formed upper lid. Case 3 is about a 63-year-old female who presented with the right eye upper lid mass, which was yellowish nodular mass in the medial canthus area, involving upper punctum and caruncular area, and also involved the caruncle area. She has the past history of upper lid mass excision done in 2014, and which was histopathologically confirmed as sebaceous gland carcinoma. So this was the case of tumor reoccurrence with the involvement of medial canthus. tumor removal created almost, in this case, almost 50%, 50 to 60% of the defect, and also involved the middle canthus area. So here we needed a flap which will cover both the defect as well as will form the middle canthus. And we chose to take the glabellar flap here, and we got a very fine result. And we can see the 6-month photograph of the patient with a well-formed upper lid, well-formed middle canthus. Another case is about a 40-year-old gentleman who presented to us with a history of chemical injury in the right eye upper lid, and due to chemical injury he has a right eye upper lid secretial ectropion with lateral lagophthalmos and exposed lacrimal gland, which was causing the persistent congestion and inflammation. You see, he had also a corneal scar due to the heel PED. So in these cases, in these cases we go ahead with the, just a minute, there was a subciliary incision was the incision near to lid margin was given, and the contracture was released, and full thickness skin grafting was done. So in this case also lagophthalmos was corrected, upper lid ectropion was also corrected. Case 5 is about management of eyelid changes like eyelid margin keratinization and entropion in secretial ocular surface diseases like SJS, OCP are very challenging. So lid margin MMG is a well-established procedure to stabilize and maintain the good ocular surface. First of all the keratinized lid margin conjunctiva is removed, and the full thickness tarsal fracture is done to correct the entropion, and raw area is finally covered with the MMG, which is also wrapped around the lid margin. So this is the poster photograph with a well-formed lid, and lid margin also covered with the MMG we can see in this case. So this is a similar case presenting with the lower lid entropion causing the pannus formation, subsequent persistent ocular surface inflammation also, and also causes the shortening of tarsal conjunctiva. So whenever there is a shortening of the tarsal conjunctiva, and we need to treat these cases with the entropion correction should be done by the cartilage graft, and lid margin MMC should be done in these cases. So case 6 is about a gentleman who has a history of trauma, followed by which he developed the retraction and the lagophthalmos. This case was not managed surgically, but just managed by the repeated injection of 5-FU around the scar. There was a relaxation of the scar, the lid retraction was corrected, and lagophthalmos was corrected just by the 5-FU injection. So intralesional injection into the scar and around the scar is given by 1:1 dilution with the lignocade, and this can be repeated at the 4-week to 6-week interval. So my last case is about a canthal dystopia and deformities. You can see here this gentleman, 40-year-old gentleman who developed middle canthal dystopia and lagophthalmos after history of trauma. And this case was managed by middle canthus fixation for the correction of middle canthal dystopia and J-plasty. And at the final follow-up, patient was having a good middle canthus, and lagophthalmos was also corrected. So yeah, thank you.
Thank you, Dr. Neha. We are running short of time. So next presentation is by Dr. Namita Kumari. The topic of discussion is contracted socket management. She is consultant at Saraf Eye Hospital, Delhi. Dr. Namita, please.
पेन ड्राइव दे दूँ
ये वीडियो आया नहीं आया फिर हिल रहा है क्या या तो इससे लगा दे पेन ड्राइव ये हिल रहा है ये तुम्हारे में कुछ गड़बड़ हो गया नहीं छोड़ दो पेन ड्राइव लगाओ टाइम नहीं है डोंट पेन ड्राइव लगा दो कुछ इसमें प्रॉब्लम हो गया इसमें कॉपी हो जाता है
नहीं ऑटोमेटिक
इसमें बहुत सारा कुछ है।
Good evening, everyone. Thank you, Gyan sir, for a nice, kind introduction. I won't take much time. Thank you, AIS and Scientific Committee, for giving me this opportunity. I'm just going to cover a very common topic, that management of the contacted socket, and this is done by all the oculoplasty surgeon also and simple ophthalmologists also. So coming to the what is the ideal socket. Ideal socket is the socket that has a bell central implant in the interconal space with a good volume correction, adequate surface, and the normal eyelid position, and the good motility. So any deviation from the ideal socket is leading to the basically the contacted socket. So contacted socket, coming to the contacted socket, the etiology, it could be the congenital, the clinical anophthalmos, microophthalmic eye, cystic eye. And for the acquired one, it could be the post-trauma and surgery-related, post-trauma fibrosis, faulty surgical technique, when you are not basically respecting the conjunctiva and doing the conjunctival dissection not well in the primary EV session, during primary EV session surgeries, multiple socket procedure. Ocular surface related is the mainly cicatrizing disease of the conjunctiva and the severe socket infection and the inflammation. Prosthesis related is the ill-fitting prosthesis and the not bearing of the prosthesis, implant migration and exposure, and etiology related is the chemical burn and the post-irradiation. So coming to the evaluation of the socket, there are the 6 main things that we need to see is like how much the volume of the socket, that can be basically assessed by the superior sulcus deformity grading, area of the socket, the surface we have to look, is it dry or wet, the position of the eyelids and motility, extraocular motility, and the associated bony hypoplasia or shortened aperture. So the most common classification, we all are aware of the Gopal-Krishna classification. It's a grade 1 is the shortening of inferior fornix or selving of inferior fornix. Grade 2 is the shortening of the both, and grade 3 is the shortening of all fornices, and grade 4 is along with the horizontal and vertical aperture dimension reduced. And grade 5 is the recurrence of contracture after repeated trial of reconstruction. So this is just pictorial representation of all contacted sockets. So there's one thing is that the post-enucleation socket syndrome, where there's a no implant is there, and that lead to the migration of the superior orbital tissue and leading to the superior sulcus deformity, upper eyelid ptosis, enophthalmos, and the lower eyelid laxity. So this is a patient of a RV survival that presented to us with the complaints of that ill-fitting prosthesis and having that the post-enucleation socket syndrome. So the most important correction is that the volume correction is important, and it will correct the superior sulcus deformity and enophthalmos, and also it will maximize the prosthesis mortality. And once you will correct the volume with the orbital implant, it will also act as a growth or stimulation for the orbital growth. That's very important. So it can be corrected by the primary implant, it can be secondary implant, and it can be by the DFG. The similarity for the surface, it can be done by the, for a small surface contacture, it can be done by the AMG plus for, depending on the need of the fornix formation suture, and MMG plus fornix formation suture, and again the DFG, because it provides both the volume and the surface. Coming to the eyelids, eyelids is important part. It's because provide cosmesis and minimize the lag, also the lag ophthalmos post-operatively. So you can, depending on the condition, if there's any cicatrizing entropion is there, you can perform the eyelid lengthening procedure by the cartilage. And also if there is some ptosis, you can correct by using levator resection depending on the LP section. So this is just a simple table to show that how to proceed with the contacted sockets. Like if there's a grade 1 contaction where it's just lower fornicial selving and shortening of there, and there is no volume deficiency, then just a formation suture and just with AMG can do well. And if it's associated with the volume deficiency, then you can plan with the secondary implant and along with the fornix formation suture. Similarly, with the grade 2 socket where the upper and lower fornix is there involved, so the surface is contactual. So you have to then do the MMG and again the fornix formation suture. And if along with the volume deficiency is there, then it's a secondary implant with MMG. So this table actually sums up how to approach basically in all the grade of socket along with that. Grade 5 is like where we wanted to go straight forward with the exentation processes. So there's one very common thing is that what is the difference between the lower eyelid selving versus the lower eyelid shortening, because in the first picture you can see that there's just a lower eyelid selving. So here just a simple fornix formation suture can correct it. There's no need of doing any surface procedure. Here this is the grade 1, there's a lower eyelid shortening is there, and here you might need the MMG. So basically in the selving that is the space is there, but just the fornicial attachment has not, detractor is not there. So then you have to just pass the FFS to correct the inferior lower eyelid selving. Coming to the fornix formation suture, it's just a simple, it's a procedure that once what you do is like you pass this 40 double arm silk suture and you take this conjunctival tissue and pass at the orbital rim, and you take the bite to the periosteum and come out through the surface and then pass through the bolster. And it basically creates an adhesion between the subconjunctival tissue and along with your orbital rim. And that's how it depends the fornix and form the space for your prosthesis. In the time, this is like I must just skipping with this fornix, this video. So this is just a mucous membrane graft video that we have given the incision. Then we pass the fornix sutures, and then we have taken the measurements, and then we taken the adequate amount of the mucous membrane graft from the lower lid mucosa and then put at the bed. So another thing is the dummies fat graft. So what is the indication for the dummies fat grafts? So it's a contracted socket where along with there's the volume, there's also surface loss. There's a failed multiple socket surgeries, post-enucleation socket syndrome, and difficult socket post-trauma and chemical injury. And in the cases of the congenital anophthalmos. So what is the, how we do that? This is like upper and outer, usually the quadrant of the gluteal lesion is the preferred. Yeah, any non-hair bearing area in the abdominal area can be taken for the dummies fat graft. And then you have to take this, mark the first thing that in the discoid shape, and then what you have to do, the infiltrate the lignocaine with the ADR, and you have to just see that the dimpling on the skin, the pudgy orange appearance. And then you excise the epidermis with 15 number blades, and then you take a 11 number blade and go deep, and with the help of scissor you just remove the this fat. So this fat will the dermis will provide the surface, and the fat will provide the volume. So securing, this is the steps where I'm just showing that how to just secure this fat with the 60 vicryl suture and then pass the fornix formation suture. So the advantage of the dummies fat graft is gives the volume augmentation, provides the surface lining, so rarely extrusion is there, and reduces chance of infection and grows with the age. Disadvantage is that the donor side morbidity is there, fat atrophy and the sizing of the graft can be there, and the motility is limited, and the long rehabilitation period. There is also reports of using antimetabolites in the reconstruction of severe anophthalmic socket contraction. However, I have not used in any case. So I'm just showing the two cases that how I managed this. So this is a 65 years old male, had some kind of measles viral infection in the childhood, and using some stock eye for the last 35 years. And when he presented to me, in this situation, it's almost you can say that this is a grade 4 contraction socket, and with the thiacical eye. So there was a two things, that there's a severe volume loss and severe surface contraction. So option is like going enucleation plus implant and MMG plus FFS, DFG plus MMG plus FFS, and exentation processes. So however, the patient is not ready for DFG plus MMG FFS, and also it's carry the two side, basically DFG and MMG carry they will be the two morbidity at two places, the donor side. So I went in this case for the enucleation implant plus MMG, and enucleation is this is the first post-op picture after just the volume correction after enucleation plus implant, and this is just after the MMG. So this is how the patient was there, at the presentation and then after the rehabilitation. We wanted to do the one stage of MMG again, but patient is satisfied with that, and in other eye he also has the ptosis and he doesn't want any correction for that. So there's a case 2 is like, this is a 12-year-old retinoblastoma survival, a status forced chemotherapy, and she has also received that EVRT at that time as a multimodal treatment for the orbital retinoblastoma, and she has grade 4 contracture with the dry looking surface. So this patient also, the implant is there, you can see that, and the volume is almost adequate. So this patient is also, what we did is like MMG. So this is after the first stage MMG, the lower with the lower FFS sutures, and this is the second stage when we went MMG with the upper fornix suture, and she needs some surface correction for especially for the lateral canthus. There is still there is a shortening there. So for the socket patient, I think the best is you need the proper evaluation of the socket. Detailed surgical planning should be discussed with the patient, because there is a need of multiple surgeries, and you also need a good ocular support, because the ultimate aim is your cosmesis. Thank you.
Thank you, Dr. Namita. Now we are concluding this session and request the moderator to next session to start. Dr.